Welcome everybody. Let's talk about hyperosmolar hyperglycemic state. HHS, hyperosmolar, is regarded as characterized by hyperglycemia. This hyperglycemia and plus other solvents, when they increase in the concentration, leading to high plasma osmolarity. Usually in this patient, ketonemia is absent, and acidosis, if present, it's mild. Usually it's not present or it's very mild. HHS develops gradually over days or weeks, usually happen in type 2 diabetic patients due to a combination of illness, especially infections, leading to dehydration and relative insulin deficiency. There is relative insulin deficiency. In most cases, there is enough insulin to prevent production of ketone and therefore acidosis. However, the patients are very ill and lactic acidosis due to infection may supervene. So what are the clinical features and investigations? HHS usually similar to DKA in presentation, but patients have more severe disturbance in the level of consciousness. Sometimes it leads to coma. Blood glucose is very high, more than 30 millimole per liter. Do not read accurately on bedside testing kits. Serum osmolarity should be calculated and measured in the laboratory. How we calculate this? We calculate the serum osmolarity by 2 sodium plus urea plus glucose. This should all be in millimole. For example, if the glucose in milligram per deciliter, you have to divide by 18 in order to make it millimole. So the normal serum osmolarity range is approximately between 275 to 295 milliosmol per kg. Values more than 300 means there is a significant hyperosmolarity. But to diagnose HHS, it should be more than 320. And more than 320 usually associated with alterations in the cognitive and conscious level. So the characteristics of HHS allowing differentiation from other hyperglycemic state is that there is a marked hyperglycemia. Usually it is more than 600 milligram per deciliter. Usually the acidosis is mild, pH more than 7.3, and bicarbonate more than 50, and ketonemia less than 3. So there is little ketone and little acidosis, but there is marked hyperglycemia. This leads to marked hyperosmolar state, and it usually more than 320 milliosmol per kg. Because when glucose increases, it will lead to osmotic diuresis, so the patients will get hypovolemia. So the patient will be in dehydration state. What is the management? The main management of HHS is fluid resuscitation. A similar fluid regime to DKA can be used. However, patients with DKA, with HHS, usually they are elderly, they have poor cardiac and renal function, therefore they have very low threshold to give them fluid. So you have to have central venous pressure or some other guidance in order to fluid resuscitate the patient. Another important thing is that many of these patients, they have high sodium level. So if the sodium is more than 150 millimole per liter, instead of using 0.9 normal saline, you have to use half saline. The half saline is called 0.45 sodium chloride instead of that one. If the glucose is less than 250 or milligram per deciliter or less than 40 millimole, you have to change the fluid to 5% glucose. Again, osmolarity should be calculated frequently in order to monitor the response to treatment. What about insulin? Insulin, you should not give insulin in the first few hours or in first hour of treatment of HHS. It should be commenced if IV fluid fail to reduce the glucose. So falling less than 5 millimole per liter per hour of glucose means that it is you have to start with insulin. Or if there is significant ketonemia more than 1 plus, in that one you have to start with a low dose fixed rate insulin in 0.05 units per kg per hour. So unlike DKA, you don't start insulin very soon. You have to wait the response of glucose by fluid. If not responded, then you start with fluid. What about potassium? Giving potassium is the same as per DKA guidance. It means if more than 5.5, do not give potassium. If the potassium level between 3.5 to 5.5, you have to give about 20 to 40 milliequivalent per each liter. And if less than 3.5, you have to give 40 milliequivalent per liter over 4 hours or 60. Metformin should be stopped to prevent development or worsening of the lactic acidosis. Most of these patients is because they have increased risk of arterial and venous thromboembolism. You have to start with prophylactic low molecular weight heparin like Clexane. If infection is suspected, you have to give broad spectrum antibiotic. Most of these patients usually have an infection. So the key point is that patients with HHS have hypovolemia, marked hyperglycemia, and increase in the osmolarity state more than 320. Usually they have no significant ketonemia, very little ketonemia, and very little acidosis. The treatment is, most importantly, you have to do IBCD in the first, then fluid resuscitation. If sodium more than 155, you have to start with 0.45 saline. Insulin is only given if glucose failed to reduce by IV fluid or there is significant ketonemia. Potassium, same as DKA. Low molecular weight heparin if the patient is having risk of, most of the patients because of hyperosmolarity, they have increased risk of thromboembolism, so you give prophylactic low molecular weight heparin, and also antibiotics if there is suspicion of infection. Thank you.